Thank you so very much. I want to make sure that you can see my slides. Is that correct?
Yes, it looks great.
Awesome.
Thank you.
And it was a little bit last minute, but that's okay. Sometimes it's easier to get things done at the last minute than it is to schedule them 6 months in advance. So I'm talking today for awareness, Hepatitis, HCC Awareness Month, about early detection and surveillance for liver cancer. The agenda really is to talk about who to screen, how to screen, and what to do with the results. And as a reminder, there are two guidelines out there that are pretty up to date. The European guideline is the more recent one in 2025, and then the AASLD guideline from 2023. But these are free resources available to everyone. They're definitely large and lots and lots of information, but they do have some pictures in them. And most of what I'm going to cover is going to be reflected from these guidelines. I do have some disclosures, none of which are actually relevant to liver cancer specifically, but always important to know what your consultant is doing. And then for context, liver cancer is a global problem, but the etiology and the prevalence are definitely different. So you can see this is a world map. The darker areas are where liver cancer is more common, and as you would expect, you can see that in East Asia, it's high prevalence and high incidence, and that is driven predominantly, not exclusively, but predominantly by hepatitis B. Whereas in North America, here you can see that the etiology is a little bit different in that our we don't have quite as much prevalence and incidence, but here hepatitis C still drives the majority of liver cancer. So that's an important thing. Hepatitis C is a curable virus, but it's our cirrhotic patients with hepatitis C, even after cure, that continue to have liver cancer rates. Now, that is quickly being eclipsed by fatty liver disease. The slide is old. You can see we're still calling it NASH and not MASH, our new terminology, and then alcohol. And then you can see that in other areas, these demographics are really different. So Eastern Europe and Central Europe having a lot more alcohol is a factor. So it does not mean that we screen or treat patients differently, but I do think that the skill set that you need to help someone manage alcohol use disorder or alcohol-related liver disease is going to be very different than someone who has viral hepatitis as an explanation. We also, rank our prevention into different types. So primary prevention makes sense, right? This is preventative hepatology. This means don't let something occur. Vaccines, healthy lifestyle, curing hepatitis C at an early time, not when you have cirrhosis. Secondary prevention is now knowing that you're going to look for something and someone has risk to find it at an earlier time point. And this is a lot of what we're going to concentrate on in the lecture today. And then tertiary prevention is really to prevent recurrence. And so this is someone who's got liver cancer, and now you're going to do something to decrease the chance of that liver cancer coming back. And here again, antiviral therapy and curative therapy for hepatitis C are really, really important. Our guidance statements, this is kind of messy. I tried to make the bullets in red, but really concentrate on preventative things. Vaccination for hepatitis B. So in the United States, vaccines are a little bit of a political hot button, but we still are advocating for universal, birth Hep B in all newborns. And that is not just the US, the WHO also strongly advocates for that. So birth dose vaccination and completing the full 3-dose series. Antiviral therapy for hepatitis B and C in patients who are appropriate for treatment. A healthy lifestyle, which includes low risk or abstinence of alcohol, controlling your comorbid conditions such as diabetes, obesity, and then coffee consumption is probably of weak evidence, but it's really the only chemoprevention that AASLD recommends. They do not advise using other things such as statins or aspirin to decrease liver cancer rate, but do advocate for coffee consumption. Now, definition. So now we're moving now into our secondary prophylaxis, our screening. There is a difference between screening and surveillance. We often use these words interchangeably, but screening is actually taking something and doing it to an asymptomatic individual. Surveillance is serially doing that. And so in a person who's liver cancer risk, you need to actually take your screening option and serially apply it. So we often will talk about surveillance, but surveillance doesn't always reflect what we're using to screen. So screening and surveillance are often flipped around, but they are slightly different. When we look at who to screen and who to survey, we know that the risk of developing liver cancer really drives the risk benefit because you want to make sure that you're applying something that's going to find it at a place where it's felt to be appropriate and also cost beneficial. And so the lowest hanging fruit are individuals that have at least a 1% or higher risk of annual risk of developing liver cancer. And here it's cirrhosis of any etiology, which in the world means Hep B, Hep C, alcohol, and non-alcohol related fatty liver diseases. Those are the four biggest drivers. But if you have cholestatic related cirrhosis, you have methotrexate associated cirrhosis, it doesn't really matter. If you're cirrhotic, you need liver cancer screening. If you are a child's PUC, so that's a decompensated cirrhotic, a person with cirrhosis and lots of symptoms, and you are a transplant candidate, you need to be screened. I'm going to get into the controversy in this, but our guidelines would say that if you are not a transplant candidate and you have advanced disease, you really don't need surveillance because you are more likely to die of your underlying liver disease than you are of an early cancer. And I think that, that's hard messaging, right? You never want to tell a patient that that we don't care if they develop cancer because they're going to die from something else. But, that in our guidelines would be a niche that you are really advocating for surveillance in a group of individuals where you have options to treat their cancer and not just someone who is ill anyway. Our non-cirrhotic chronic hepatitis B patients are where we spend a lot of time focusing, and this is individuals based on where you were born and then your gender. So if you're a man from an endemic country at the age of 40 or older, or a woman 50 or older, you need liver cancer surveillance. Individuals from Africa, we recommend screening earlier. Some of our guidelines recommended starting at the age of 20. Now there is wiggle room in here, but we recognize that sub-Saharan Africa does have probably either genetic or environmental risk that adds to the hepatitis B, and so their cancer risk occurs earlier. Hepatitis D should probably also be added into that box, even though it's not in the ASLD guideline. Family history of liver cancer, and then your page B score, which I'll cover next. And then those that have insufficient risk include hepatitis C with advanced fibrosis, but not cirrhosis. Now, the European guidelines used to, in the past, advocate for screening that population. I think that also came out. And then non-cirrhotic NAFLD, or patients with metabolic associated liver disease that do not have cirrhosis. But it's important to recognize that although the annual incidence is low, about 1 out of 4 patients with MASLD who have liver cancer do not have cirrhosis. And so it's just because it's such a huge group of individuals that the risk-benefit ratio did not come out to advocate for screening. It does not mean that there is no risk in those patients. So when we talk about page B is a very easy math equation that's based on age, gender, and your platelet count. And then it was modified to be a little more permissive in the platelets, and we call that the modified page B. And you can see that it's just kind of like a math equation. And if you have a page B score or a modified page B score of 10 or higher, your risk of liver cancer is high enough where you start to warrant liver cancer screening. So it just means that people do not age well, so our risk of liver cancer goes up as we get older. It's higher in men than women, and platelets are bringing in advanced fibrosis or risk of cirrhosis and portal hypertension because the more advanced your liver disease, the higher risk of liver cancer. Now, when we look at this, you can make page B better. And this is looking at page B that adds diabetes, recognizing that these metabolic risk factors also increase cancer risk. And this was a recent publication in the Journal of Hepatology that demonstrated that adding diabetes to the traditional modified page B score increased the identification of individuals that were higher risk. And so it means that you can't look at just one factor and ignore the rest of the factors in your patient. If you have someone who has Hep B and also metabolic risk and is a man with a family history of liver cancer that is getting older, that you want to really keep them engaged into these surveillance protocols because their risk of liver cancer is high enough that you don't want to miss that. Now, why do we do surveillance? Well, it used to, that when you look at things like why we do things, we like to know that doing something leads to value. And hands down, in multiple studies, surveillance has been associated with improved survival in individuals with cirrhosis. So we kind of break down when we're looking at patients that don't have cirrhosis, but if we concentrate on the cirrhotic population, you can see that the studies clearly show that we find cancers at an earlier time when curative options are available, and that improves survival. So when we try to, engage our patients in surveillance, right, people like to do things that they think are not going to just inconvenience them, but are going to keep them healthy. It's important to emphasize that this is why we do this, not because you're inevitably going to get cancer, but if you do get cancer, we want to find it at a time when curative options are an opportunity. So our guidance statements, again, we just went over this, but they say if you're at high risk of developing liver cancer, you should be entered into a liver cancer surveillance program. And this is strong recommendation level 2. We already talked about the fact that if you're not a transplant candidate, child C cirrhotics do not need to be surveyed, although that is arguable. And if you are a liver cancer, a liver transplant candidate, it's especially important to undergo surveillance because it starts to change access and prioritization for transplant. So how do we survey our patients? Our guidelines still recommend using ultrasound and alpha-fetoprotein at 6-month intervals, and that's an evolution. In the past, we recommended only ultrasound. Alpha-fetoprotein was controversial. Now our guidelines say AFP and ultrasound every 6 months. ASLD does not recommend cross-sectional imaging. There are many of us, I think if you have a show of hands, that say, oh, I do an MRI or CAT scan once a year. I do an ultrasound on the alternatives, and we'll talk a little bit about why people do that. But guidelines say that that's not the right answer. The right answer is a high-quality ultrasound and alpha-fetoprotein every 6 months. And then you can see that's our starting point for our algorithm on how you're going to take care of your patient. Now, it's important to know that ultrasound is not always a good quality study. And so you want to make sure that your ultrasonographer is reporting your VIS score. What a VIS score is kind of like, was this a good study or was this a terrible study? So if your VIS score is A, it means that you had minimal limitations, you think you saw everything, and you should trust the results. If your VIS score is B, it means you had some limitations. And if your VIS score was C, it meant that you put an ultrasound probe on the person, but you don't know what you saw. And that is not a reliable study. And our algorithm will tell you how to follow a person whose VIS score was terrible. Now, ultrasound isn't a great study, and this is why people will do annual or semi-annual or continue to push for an alternative that's not ultrasound. But you can see here that ultrasound alone has a very poor sensitivity for finding liver cancer at an early time. If ultrasound suggests that a person has cancer, it is highly specific. So trust it, do not ignore it, but it will not reliably show early cancer. So it's not an ideal surveillance tool, even if it's what's recommended, and that's because it's operator dependent. If your VIS score is bad, it's not worth very much, so it has less precision in patients with more advanced disease or people who have limitations like obesity. It's hard to find tiny lesions. Now, when we talk about transplant, we like cancers to be 2 centimeters, so that's why ultrasound still comes out being a good surveillance tool. It finds people at a time when curative options are still available, but does not find them early. And then when we look at people who have suboptimal ultrasounds, about a third of individuals will have an ultrasound that's really not worth that much. And so, that's an important thing when you know that you're going to order a study and then you have to talk to the patient in front of you about, I got this tool and the tool was a bad tool and now we have to do something else. Because as we talk about why people don't get surveillance, it's really important that that's part of the equation. Now, adding AFP makes the study better. It doesn't make it perfect, but it makes it better. And so you can see that the sensitivity increased from 45% to 63%. And the nice little pretty curve where ultrasound with AFP is in yellow shows that this is really a cost acceptable curve as opposed to ultrasound alone or no surveillance at all. And so that's why the guidelines now advocate for both the tumor marker as well as the study. Now, nothing is going to find, something. You aren't going to find something if you do not do it. So utilization is one of the biggest barriers to liver cancer surveillance. And you can see here that in individuals with cancer, we found that the main reason that they found cancer at a later time is that they just didn't undergo surveillance. And so, why did you not undergo surveillance? Well, cost, difficulty in scheduling, uncertainty on where to get the ultrasound, transportation. These were all common reasons that people didn't engage in surveillance, whether you looked at three different Texas, institutions, and now Texas is not everywhere, but I would say that these are probably very common reasons that our patients don't get what we recommend, irrespective of where the patients are. We also know, so this is looking at over 1,000 patients with cirrhosis who had liver cancer. When you find things at a symptomatic time point, so when we find cancer not through surveillance, we find it at a time when curative options aren't always available. But in our patients that were found to have liver cancer, only 37% of them had regular outpatient care. So you're not going to find something in a person who's not coming to clinic. Only 32% had cirrhosis recognized. So you're not going to surveil someone if they didn't even know they had cirrhosis alone. And obviously, if you're not seeing your patient and the patient doesn't know they have cirrhosis, you're not ordering surveillance. And so you can see that there are many barriers or many different obstacles across the spectrum in patients who have cirrhosis, that were not getting surveillance and then were found to have cancer. So when you ask patients really would love to have a tool that's not an ultrasound with alpha-fetoprotein every 6 months. And trying to pull patients in a way that makes them an educated participant in their health care. This study that surveyed individuals on preference looked at 5 different factors. Sensitivity, so were we likely to find something at an earlier time point, not specificity, but sensitivity. Physical harms, like were we likely to scare you, make you do lots of tests. Financial impact, test logistics, and then the duration of testing. And so when you asked people about these things, the most important thing that they found was, is this an important study for me? So if you can invest them in why this is important, that's ultimately people want to know that this is something that's going to help me stay healthy. And the majority of them, small majority, but majority would actually do something if you could convince them it was worth doing. After that, logistics and financial impact were important. And when you lined all these things up, patients really felt that an MRI or an abbreviated MRI, which we'll talk about a little bit, or a blood-based biomarker was much better than doing either ultrasound alone or ultrasound with alpha-fetoprotein. And maybe that's just how the survey, was phrased, but it's hard to imagine that you're going to get your patient to do something they don't want to do, even if your guidelines advocate for it, if they do not feel that it's important. So MRI is absolutely more sensitive than ultrasound with alpha-fetoprotein. And you can see here that specificity, ultrasound and MRI are pretty close. MRI still is a little superior, but 97 versus 94%. But if you're looking at sensitivity, ultrasound alone was only 28% compared to 86%. And that does not mean that we all need to do MRI, but it tells you why clinicians that are not following guideline recommendations don't follow guideline recommendations. Now, if we do an abbreviated MRI, this is a quick MRI. Remember, if you put your patient through an MRI, it's usually an hour or so study. It's it's kind of a tight space. It's not an easy tool to apply serially to the person in front of you. They would love to know that they had one MRI and that was good enough for life and they were done. If they're trying to get an MRI at 6 or yearly intervals, that probably isn't something that people are going to want to do over and over again. But an abbreviated MRI is a shorter sequence. It's like a 20-minute MRI, a little bit less expensive, but unfortunately, when you look at this study, there's lots of words here, but the most important thing is in the red box that it underperformed in patients with more advanced disease compared to a person who has child's A cirrhosis. So we know that the more advanced disease, the higher the risk of developing a liver cancer, and you don't want to use a tool that is supposed to be better and reassure a person that they don't have risk for liver cancer if it underperforms in the highest risk group. So now let's talk a little bit about alpha-fetoprotein. So AFP is not perfect. About 30 to 40% of liver cancers don't make AFP. And bigger cancers are more likely to make AFP, but not all of them. About 30% of people with an abnormal alpha fetoprotein don't have cancer. That doesn't mean that they aren't at risk of developing it, but it means if we look really, really hard, we don't find a cancer. And that's especially true in things like hepatitis C or more inflammatory liver injuries. The higher the AFP, the higher the rate of liver cancer. So that just gives people anxiety. If my AFP is 30 and you can't find a cancer, everyone's going to convince me I'm likely going to get one. That's going to make me feel bad. But we do know that that's true. And so people who have higher alpha fetoprotein do get slightly different surveillance recommendations. And then an AFP of 20 is the best on the ROC curve. However, AFP of 19 doesn't mean you're at low risk of cancer, in 21 that you definitely have cancer. It's just that seems to be the place where we draw the line where we start to worry. AFP does also have prognostic impact. So it's one thing if you're using the tool for screening, it's another thing if you're using the tool for prognosis. And here, AFP strongly has prognostic impact on mortality, prognosis after resection, and prognosis after liver transplantation. And so it starts to be part of our recommendations for downsizing a liver cancer if you're going to try to get someone to go towards transplant. Now, there are other biomarkers. So this is a list from the AASLD guidelines looking at alpha fetoprotein L3. This is a more immature lens 3 form of alpha fetoprotein. DCP, which has been sometimes linked to tumor thrombus in the portal vein, but this is another tumor marker that's often added to panels. There are multi-target algorithms, which means they're looking at other tumor markers, GALAD, which we'll talk about next, and then the Doylestown Plus, which is just using some tumor markers in addition to alkaline phosphatase and ALT, AST, and other markers such as age, putting it together in an algorithm. And you can see that some of these, all of them have very reasonable specificity, but sensitivity is significantly different. Although Doylestown Plus seems awesome, it's probably one of the less validated and not very frequently used tools. So GALAD is something that we often will use. And so GALAD is self-descriptive. It stands for gender, age, AFP L3, AFP, and DCP. And when you add these things together in this very complicated mathematic tool, it gives you the probability of developing a liver cancer over a period of time. And so you can see that when you look at GALAD above just AFP L3 alone, it does improve the performance of the biomarker. And that would make sense if you know that age is going to be impactful and gender is going to be impactful. You're adding 2 additional risk factors to your biomarker. So this was an abstract, which was very interesting. I think it was called the SMART HCC. This took many things that we already have talked about, added liver stiffness, and threw it into a machine learning algorithm. So this is futuristic, but it really suggests to us that we are going to have improved tools over time, although this is not yet standard of care, but it really suggests that we might be able to use some of our exciting AI machine learning algorithms to identify patients at higher risk for liver cancer. So back to our guidelines. You've done your ultrasound, your radiologist said that your VIS score was great, your AFP was normal, less than 20. Repeat this, survey in 6 months. Your VIS score is B, which meant that it wasn't terrible, but it certainly wasn't great, or you were found to have a lesion that was less than 1 centimeter, so a small lesion on ultrasound. That would give everyone anxiety. And still with the alpha fetoprotein that is normal. Here the guidelines say you should repeat your surveillance now at 3-month intervals, possibly 6, but you're going to repeat it a little bit sooner. And you're going to continue to do that until you're sure that the area is stable, so maybe 1 or 2 cycles. And if it grows, your lesion grows, or your VIS score remains terrible, you're going to want to now do cross-sectional imaging, so a diagnostic MRI or CAT scan. And this is evidence-based. The reason that we recommend going to an ultrasound at 3-month intervals and not cross-sectional imaging is that when you look at these small lesions, very few of them become liver cancer, so 25%. Now, this study, I put it all out here because only 28% of individuals actually underwent guideline concordant ultrasound in 3 to 6 months. So it's hard to grade something based on data that you did not get. But in those that had escalated surveillance, only 1 out of 4 were really found to have liver cancer. So it's supposed to reassure us that not jumping to cross-sectional imaging is appropriate. I will tell you, though, that most of us, if you take a show of hands, would probably do a CT or MRI in a person who had a less than 1 centimeter lesion on their ultrasound, because we already described the fact that ultrasound isn't very good and we're all nervous individuals. And unless your insurance says you have to pay for this out of pocket, you're going to want to do something that reassures your patient that they do not have liver cancer. So if your VIS score is C, so remember, this is much more likely in your child's BC cirrhotics, or someone who has significant elevated BMI, you really need to do cross-sectional imaging. Your radiologist had told you that your ultrasound was worth nothing, and you cannot rely on that. And so here it doesn't mean immediately, but most of us would convince our patients that your ultrasound underperformed and we need to do something more accurate. All right. So how often does that occur? Well, nearly 20% of ultrasounds are suboptimal for liver cancer screening. So just a reminder that when we're talking about what we're using and talking about it to the patient in front of you, if you have a person who's got child's B minus, so more decompensated liver disease and a BMI of 50, you can be pretty sure that their ultrasound isn't going to be worth much. That doesn't mean that you have to go right to a CT or MRI, but it's important to at least know that when you get those results, you're going to have to make sure your ultrasonographer told you if it's a high quality study. Sometimes they don't report a VIS score, but they say visualization was poor, or bowel gas was in the way, or the liver was dense. If you really need to know, please get another study. These are all code words for I didn't see a whole lot. And then you want to make sure that you're looking at your patient and being sure that you're doing what's in their best interest. All right, so now let's move on to the fact that we have a suspicious lesion. So now we have something that is 1 centimeter or greater. It was confirmed by cross-sectional imaging. What do we do with this? And certainly here, you want to make sure you also have an alpha-fetoprotein, because that's going to help you interpret the risk of your lesion. When you have a lesion, now we pull in a group of criteria called LIRADS criteria. These are really developed by a radiologist to help identify someone who has something that's pretty convincing for cancer. The factors that go into this are arterial hyperenhancement. So arterial hyperenhancement is a code word for bad. And so if it's an enhancing lesion, you're already going to start to worry about it. Size matters. Things that are bigger are more likely to be cancer. Something that's tiny is less likely to be cancer. But if it's tiny and enhances and washes out, it's more likely to become cancer, even if the radiologist says it's LIRADS 4, which means likely cancer, but not cancer yet, because these are things that are more likely to grow and become something bad in the future. The other features besides size are capsule enhancement, and then wash out, and then threshold growth, which means that it enhances, the capsule lights up, and then it washes out. This is radiologic buzzwords for liver cancer. And then if it grows between imaging, well, even if it's not liver cancer, it's something bad. Now, if it grows over 10 years, that's less bad. But if it grows over 3 to 6 months, that's something that you're going to need to worry about, even if you think it's not HCC. It's something not good in the liver, and we need to make sure we don't ignore it. So it also is nice to know that you can't apply LIRADS to everything. That does not mean the radiologist isn't going to report it, but LIRADS has not been validated in patients who do not have cirrhosis. So in your chronic Hep B infection, non-cirrhotic population that you are surveilling, in theory, your LIRADS score should not be used. That doesn't mean we don't, but here guidelines would advocate for biopsy in this group of individuals, or at least thinking differently about the patient in front of you. Now, once you're sure that you have something that's meaningful, so here you have a LIRADS 3 or 4 lesion, or what do you do with something that you now are telling your patient could become cancer, or is probably cancer? What are we going to do with this? And so this nice little breakdown in the guidelines tells us that if it's LIRADS 3, you're going to watch it at 3 to 6 month intervals, and usually with cross-sectional imaging. So here, You're going to serially look at them until you're sure that it's not changing at all. Then you're going to retreat back to 6-month intervals. If it LIRADS 4, here you can see the probability of becoming cancer is almost 70%. So you have just found an early cancer. Do not reassure the patient that it's no big deal. Here you're going to want to make sure you're reviewing this in a tumor board. And if you're sure that it's likely that, let's say it didn't have all the criteria, but it's a little on the bigger side, this is a place where you might do a liver biopsy, because once you can have histologic confirmation of cancer, you're more likely to curative therapy, whether that's transplant, resection. If it's going to change how you would manage the patient, here we're going to biopsy this individual that is not LIRADS 5. All right. So non-liver cancer lesions still have risk of malignancy. So if your radiologist is telling you that this is LIRADS M, or something that could be a cancer but doesn't fit the diagnostic criteria for HCC or hepatocellular carcinoma, you want to make sure that you're following a different algorithm. Just because it's not HCC doesn't mean it's not something concerning, and you want to, throw those into tumor board again to know what you're gonna do. And then this is just a clinical trial kind of helping confirm that these LIRAD-3 lesions, which are usually regenerative nodules, do have risk of transition to liver cancer, but it was 16 to 44% as opposed to LIRADS 4, where over a year, 6 months to a year period, about 30 to 71% transition to more defined liver cancer. So if LIRADS 4 really needs to have surveillance, as opposed to LIRADS 3, where you, I guess in theory, could elect a 6-month interval as opposed to a 3-month interval. Now, once you're sure you have cancer, and this is a very complicated slide, but here we use the Barcelona liver cancer staging system to identify how to take care of the patient in front of us. If it is, here it is not just the mass itself. Other things that are important are the functional status of your patient, right? If you have a patient who has a terrible functional status, so whether they, are demented or have severe cardiovascular disease, your options are going to be a lot more limited, right? Because the protoplasm of your patient isn't going to allow you to do much. So if you have a person who has excellent functional status and has early stage cancer, you really have someone that's got a lot of options in front of them. And if they do not have cirrhosis, this is where you start to look at resection as an option. Once you start to have intermediate stage cancer, so this is a multifocal cancer, but preserved liver function. So this is someone who is outside of the criteria that transplant might be an option. Here, you could try to downstage your patient. So you're going to want to do something like local regional therapy. A radiologist will do TACE, or in our institution, we do more TARE. So TACE is transarterial chemoembolization as opposed to radioembolization. You're going to want to do something to kill the cancer cells, see what happens to the patient in front of you, and then hopefully you've got them to a point where now you can start to think about either resection if they don't have cirrhosis, or they don't have portal hypertension, or liver transplant in a person who's got cirrhosis and portal hypertension. If you have a person who's got more advanced disease, so you have portal vein invasion, you have cancer outside of the liver, systemic therapy is your option. That does not mean that we don't combine it with local regional therapy. So if you have a person who's got burden in the liver, they might still do transarterial radioembolization, but here you want to also do systemic therapy. And the systemic therapy that's first line is our immunotreatment. So you can see that this is a little bit older, because here they're talking about atezobev or durvalumab as our first line therapy, and a lot of second line treatments, as well as third line therapies. But here oncology, it's a fast moving area, and we have multiple immunotherapies or systemic options that are available to patients based on the risk of bleeding and the risk of how they're going to tolerate that. And then obviously, if you have a person who's got end stage liver function, this is really where we're talking about palliative care. The blue line here tells us expected survival, and someone who's got end stage disease really is not expected to survive very long. Even in advanced disease, if you have preserved liver function and a preserved patient function, Systemic therapy might offer this patient over 2 years of survival. And so, the word cancer is really scary. But, it's important to emphasize that in early stage cancer, we're talking about curative treatment. And if intermediate stage cancer or advanced stage cancer with preserved hepatic function, we're really talking about palliative therapy, but years of survival. And so we want to make sure that we only preach doom and gloom when it's truly doom and gloom. So this is just the simplified algorithm for unresectable cancer, that if you have a person who is not a liver transplant candidate, you're still going to do ablative therapy if it's not outside the liver. And in a person who's decompensated, um, here really their synthetic function, their liver function may not allow them to undergo local regional therapy, but sometimes systemic therapy is still an option if they have somewhat preserved hepatic function. On the other hand, if you have decompensated cirrhosis, you are not a liver transplant patient. This is where really palliative or hospice is going to be most appropriate, and why they don't recommend screening or surveilling child C cirrhotics that are not transplant candidates, because the options available to them are just much more limited. All right, so in summary, liver cancer surveillance is associated with early tumor detection, curative treatment, and reduced liver cancer mortality. So we really want to emphasize to our patients, because we have so many barriers to engaging our patients into ongoing surveillance, that this is really going to help to identify things at a time when we can cure them. I know that I have patients who have been cured of their Hep C, have cirrhosis, and they just fall off the bandwagon. They get surveillance for a couple of years and they don't come to clinic because they feel good. Patients with cirrhosis without clinically significant portal hypertension often feel great, and they just don't want to engage if they don't feel that it's important to engage. Abdominal ultrasound with alpha fetoprotein, despite the many things that I said were terrible about it, are still our recommended surveillance strategy, and liver cancer surveillance is underused for all the reasons that we talked. You're going to use the LIRADS criteria to identify how risky a lesion is, and then you're going to, change your surveillance protocols in individuals who have LIRADS 3 and 4 lesions, because the risk of liver cancer is starting to become significant. All right, I think now I tried to leave enough time for some questions. So I hopefully this was helpful for Liver Cancer Awareness Month, and I'm happy to answer anything.
Great. Thank you so much. And just wanted to ask if we're able to share your slides because I think they were really helpful with the folks on the line afterwards, if that's okay.
Absolutely. I do think I emailed them.
You did. Yes, I
I
have
think I,
them.
I might have emailed a slightly earlier version, but it's pretty close. If you want this one, just remind me and I'll send you
Oh,
anything I
no, I
updated.
was following along. I think it matched
Perfect.
perfectly. Yeah. Thank you so much. I did have a couple of questions. One kind of referencing your summary slide, and then one slide that was really striking to me, and something that we've been talking a lot about is the challenges associated with making sure that folks understand, patients in particular, understand the need for the long-term surveillance with hepatitis. And I wonder if you have any recommendations on how to communicate that to patients, and strategies that maybe have worked for you in your clinic.
Yeah, I mean, it's really hard, right? Because you want to make sure that you tell your patients things that are encouraging. And what I don't want someone to do is to leave the clinic being told that they have cirrhosis and that they're probably going to get a liver cancer. And they just are so, deflated and defeated that they feel that there's nothing they can do to improve their prognosis. I really emphasize, that when you have cirrhosis, that the risk of developing a liver cancer is about 4% per year. Now, that's obviously not true in a person who's older with untreated Hep B and child's C cirrhosis. I mean, we can devise something, but I really try to put it into the context that it's not 100%. But we want to find things at a time when cure is an option. And I like to use the word cure. Now, when I have a patient who comes in with cancer at a curative time point, sometimes we're talking that cure is transplant. as opposed to ablation, which in some people could potentially be curative, or in a resection patient, because ablation and resection really leave that diseased liver to grow another cancer. But I try to emphasize that appropriate risk, but if we find things late, we don't have options. If we find things early, we have options. I think engaging family, if they are willing, some of my patients really don't want their family to know that they're sick. And then, we find that things like setting automated reminders. So there are ways of sending my chart messages on an automated way, or, mailing things like if your dentist can manage to mail you it's time for your dental screening reminder, you probably can also manage to remember to screen your patient. And so I think that these little triggers, like, do you realize that 6 months have gone by? It's time for you to get your liver cancer screening. They are also helpful.
Thank you so much. I think Katie had mentioned in the chat, can you reshare recommendation slide for HCC screening in patients with HBV? I'll include these slides in the follow-up resources for folks as well.
That's perfect. And Katie, I will tell you that they're not identical across all the guidelines. So that some of the guidelines recommend screening Africans at starting at the age of 20. Some pull out Black Americans, or people living in America that are Black differently than others. And so the easiest is Asian men that are 40 and above, and Asian women that are 50 and above. After that, things break down a little bit, and not all recommend the page B. Sometimes we extrapolate page B to non-hepatitis B conditions, but just know that if you are looking at the European guidelines or the APOSL guidelines or the WHO guidelines, there are going to be subtle differences.
Yeah, I think that's what the struggle really is for me with Hep B and HCC surveillance, is just figuring out who I'm going to put on that trajectory, especially young folks who don't have cirrhosis. And I feel like it's a big weight for primary care to make that decision, because, you don't want to kind of recommend it. You either want to recommend it or not recommend it.
Right. I think that one of the things I've heard is that if you have a patient with hepatitis B that deserves Hep B therapy, you should be surveilling them for liver cancer. And it also allows you to have that 6 month reminder that you look for viral load, that you're not only talking to them about liver cancer risk, but are they still on drug? Have we looked for the potential complications of their medication, like bone and renal toxicity in a person who's getting TDF, or pregnancy risk in a person who might be taking entecavir of childbearing age, so that it gives you an ongoing dialogue with the person you've already chose to treat. It's much harder to take someone who is young that is not on treatment and try to find the sweet spot for when you start to screen them for liver cancer. And here, I think that family history is also really important. If they have family that has liver cancer, I'm much more aggressive and encourage them to get screened.
Thanks, that's helpful.
Uh, Jesse, I see your hands raised.
Thank you so much for that. That was fantastic. I am excited to see the page B score and the current recommendations for ASLD HCC screening. I think that gives providers something they can do in the clinic. I wonder, can you comment on patients you may not use the page B score on, or at least the page B score of threshold of 10, particularly, thinking back to some of the validation studies where they may have missed some important patient populations.
Yeah, I mean, the page B score is best validated on patients with hepatitis B. And so I think that we feel obligated to take our page B and apply it to fatty liver or hep C, and it may not work as well there. And so I think that we recognize that there are going to be limitations in how we've looked at that tool. Most of our patients with cirrhosis who, page B is not going to help identify a person who has non-cirrhotic MASLD at risk for liver cancer. But I think it does help in patients with cirrhosis of all underlying explanations. And so if it helps convince the patient sitting in front of you why they need their surveillance, and pulling in especially gender and age, just because you've been negative for the last 5 years doesn't mean that you can now stop surveillance. You want to use the tool in a way that it helps you with your clinical practice.
Thank you. Uh, Naya, you have your hand raised? Go ahead.
Yeah. Okay. Thank you so much, Professor Nancy, for this instructive talk on liver CA. I do practice in Cameroon, and like most other countries in Africa, we do not have surveillance systems in place for hepatocellular carcinoma, and we tend to diagnose most of our patients very late. In fact, a lot of patients with chronic viral hepatitis B get to know about their status at the time that they are showing up with a complication. Probably we see someone cirrhotic or someone presenting with advanced HCC before we are realizing at that time that this person had chronic hepatitis B. And survival, actually, it's very minimal. In fact, the diagnosis of hepatocellular carcinoma where I practice is just bad news because most of the patients die within months. A few of the patients that we have had the opportunity to do surveillance for, we routinely do AFPs and abdominal ultrasounds. Given that a good number of patients with HCC might not have elevated AFPs, it gets very problematic when we do see a patient with a liver lesion and a normal AFP, because additional investigations like a triple phase CT scan is not something that is very affordable for most of our patients. Many of those patients do not have any health insurance. They do pay out of pocket. So a lot of times we have to take a close look at the lesion on ultrasound, and we are judging what is the echogenicity. Literature says most HCC is hypoechoic, but it's not 100% of the time. So sometimes when we see the lesion that is hyperechoic and the alpha fetoprotein is normal, we have this tendency to like, okay, can we repeat the ultrasound in a few months, maybe 2 to 3 months, and see what is happening to the size of the lesion, especially when the patient can't get a triple phase CT. My question is this: what is your take on judging the tendency of malignancy versus benign lesion based on the echogenicity of a liver lesion? Thank you.
Yeah, that's great. And I would have to say that in the spoiled US, I don't have as much experience because we would just move to cross-sectional imaging. But you can do contrast enhanced ultrasound. So if you have the ability, the criteria are the same. So I think they just use agitated saline and dynamic ultrasound. And I think that the LIRADS criteria can be applied to contrast enhanced ultrasound. I believe in San Diego, the radiologist there probably has some of the most experience with contrast enhanced ultrasound, but my own ultrasound department, in someone who maybe was claustrophobic or had significant renal disease that precluded cross-sectional imaging, we have used contrast enhanced ultrasound. No one wants to tell you that you should do something suboptimally, but if you have a smaller lesion, doing a short interval ultrasound for growth is probably not the worst strategy because, doubling time is about 3 months on average. And if you do an ultrasound in 2 to 3 months and it's gone from 2 centimeters to 4 centimeters, well, you know that you have a cancer then and you could, treat that patient appropriately. If it doesn't change at all in size, then you start to, end up in an anxiety-provoking, wheel. But, I think that our guidelines and our clinical experience would say that some of those are going to be low grade, less aggressive cancers, but most of them are going to be benign lesions. And if it hasn't changed over, let's say 3 month interval ultrasounds for a year, it's probably not going to change. Now, will some of those truly have been cancer and will grow ultimately? Yes, but it's going to be a tiny minority.
Thank you. I had one more question. I know the hepatitis B guidelines are changing. Hopefully, we should hear them maybe at the new ASLD meeting coming up in next month. But I wonder also with that, are there plans for, and I'm not sure, maybe you are aware, but are there plans for HCC surveillance to change with those guidelines as well? And do you anticipate a lot of updates with that?
Yeah, I I don't think so. We all are waiting for the guidelines. I believe that the guidelines are now question-based. So they took a handful of important questions and answered those. Now, I have not seen the final version. The one of the earlier versions went out for public comment, and so we could see those. But I don't believe that liver cancer surveillance was prominent. And one of the difficulties with guidelines is that if you have liver cancer guidelines and then you'll have liver cancer surveillance embedded in your Hep C, your Hep B, your MASL guidelines, they all become inaccurate once one changes. And so I believe that the reason that they're not pulling that in there is that they're leaving them to the HCC surveillance guidelines.
Thank you. And we had a comment in the chat from Nicolot um, indicating that we've seen mild cirrhosis improve with hepatitis B treatment initiation in their setting, which could be follow-up from the comment from Naya as well in Cameroon.
Yeah, absolutely. And one of the important things, although guidelines now do not recommend surveillance in, let's say, stage three cirrhosis, stage three fibrosis from hepatitis C, they still would recommend if you had a patient who had cirrhosis, even with regression, that you screen that patient. And so I know that we know that there are patients who have improvements in fibrosis, but what we don't know is if it eliminates the liver cancer risk or if it just decreases it. Absolutely, someone who has no portal hypertension, very, very mild cirrhosis is going to have a lower cancer risk than someone who has more advanced disease, but it's probably not zero. We still want to find things at an earlier time point.
Great, thank you. Any last questions or comments from the audience? All right, hearing none. I just want to thank Dr. Reau for jumping in and the excellent presentation today. I think there was a lot of really great discussion and interest. And also thank the audience members for joining us today. As a reminder, I did post the slide deck in the iEcho platform, so you should be able to access all of the content that was covered today. And we will also be posting the recording on the Hepatitis B Foundation's Echo YouTube page. And I'll post that as well in the iEcho platform. But with that, I will go ahead and conclude the session. Dr. Reau, any last words of wisdom for us?
No, thank you. Thank you so much for the hard work that you're doing.
Thank you. Thank you for your work as well. And looking forward to staying in touch and seeing everyone hopefully in the new year.
Excellent. Have a nice week.
Bye. Bye, everyone.